today's webinar, Improvement and Innovation, Building a Culture of Collaboration and Innovation to Harness Our Collective Intelligence, is the fourth and final webinar in our series on health and transformation. Before we get started, I'd like to mention that we welcome your questions throughout the webinar. All you need to do is type yours into the question window, which for some is the sixth blue bar down on the GoToWebinar control panel, and hit submit. We'll get to as many questions as we can during the Q&A session after the main presentation. Finally, we're recording today's webinar and we'll post it on the Optimity Advisors website. We'll send you an email once it's up in case you want to watch it again or forward it along to a colleague. Without further ado, I'd like to turn the program over to Niamh.
Muted. Thank you, Caitlin, and good afternoon, everybody. Today's webinar will explore how health and care systems can embed new ways of working, which create the conditions to work differently, embedding innovation and improvement through continuous learning. Today, we will continue to share our experience of how local health and care systems can work in a different way, and model the kind of collaborative practice working with communities that they serve. We'll share the tools that we use to support the change and our experience of using them. So the story so far, our previous webinars introduced a framework for thinking about new ways of working. To quickly recap, the assumptions that underpin this framework include, first of all, the starting point should always be what do local people want or need from health and care. This requires a fundamental rethink of how services are designed around the needs of the population. Secondly, organisations already have lots of transformational ideas and capability in-house and could harness it much more effectively. Thirdly, the kind of accountability that is most meaningful to all of us is not up and down, but works peer-to-peer. Our colleagues and the consumers or service users are the people who matter to us. Their feedback is in real time. And finally, openness to learning from mistakes is critical. It's the only way to improve quality sustainably and requires trust and honesty. And this is where we're going to focus our discussion today. We've posed throughout this webinar a series of what we call big questions, and today the question that we're focusing on is around continuous improvement and innovation. To summarize some of the key messages from our previous webinars, the ones that we've shared have been around the importance of investing time, developing trusted leadership, and moving to peer-to-peer accountability, which includes service users and the local community. All of this together will lead to an unlocking of the real talent latent in your health and care system. You'll also remember our wiki management approach, which we presented in webinar 1. At this point, we have a clear vision and narrative for the transformation as outlined in webinar 1. We've designed and delivered a new way of working across the system that unlocks the talent of the whole community. But how do you ensure that you embed this new way of working across the system to ensure that the system continues to transform and innovate? Making a change stick is always the hardest part of the process, as we all know. Remember this from the last webinar? We recognize that we're not operating in the context of certainty here. We're instead living and working in a situation where past experience is no longer a reliable predictor. Cause and effect relationships are indiscernible. Even experts fail to make sense of conflicting signals. And there's a high-frequency, multi-dimensional turbulence at scale. And all of these are not easily susceptible to logical analysis. Coping with this uncertainty is central to the process of continuous transformation and improvement in the agile organization. So you've unlocked the collective intelligence of the broader system to create the innovation networks we discussed in webinar 3. Now you need to embed this by reinforcing the behavior of peer accountability through new performance management systems, measuring what matters, and learning from mistakes as well as success through rapid learning cycles. Peer accountability means being accountable to the people who matter most and whose feedback is real-time and connected to day-to-day practice. In transformed health and care systems, that means the people who are using the services, their families and friends, and the wider health and well-being team. This includes non-professionals. An essential component of continuous improvement and innovation is measurement. Understanding and monitoring what is changing and the impact on outcomes. There needs to be a focus on few measures of what really matters and contributes to the success of the transformed health and care system. The starting point for that is always the local community that is served by the system. This means looking at what we currently measure, automating what we can and is needed for compliance purposes, stopping what does not deliver value to the people who matter, and actually using the measurement we focus on for decision making at every level of the system. We also need to understand the difference between leading and lagging indicators. We are great at lagging indicators in health and care, indicators that tell us when something is going or already has gone wrong. When we try to find leading indicators that can act as the canary in the mine, we're not very good at focusing on those indicators that really tell us when things are at risk of going off track, and focus instead on measuring the measurable. Eleanor Roosevelt famously said, "Learn from the mistakes of others. You can't live long enough to make all of them yourself." But we also need to learn from our own mistakes. Practice provides us with opportunities to learn in a structured way from mistakes. We need to invest the time in practice to avoid the much bigger costs of failure when it really matters. But even when we fail at important times, we should never waste the opportunity to learn. We all learn through practice. It doesn't stop when we finish our formal studies, nor is continuous learning the preserve of continuing professional development programs. In the context of the speed and volume of change that we're experiencing and focused on in Webinar 1, none of us can be expected to keep on top of all the latest thinking all of the time. So learning in organizations and systems today is a collective process rather than an individual one. We know from recent examples of systemic poor care in the NHS that culture was identified as creating conditions that made it difficult to learn collectively from the mistakes that were being made. We have professions that are not supposed to make mistakes, who are supposed to be infallible, but this expectation is an impossible one to fulfill. Our own evolution is surely the best example of practice and learning from mistakes. After all, the mutations that drove our evolution were effectively mistakes in our genetic coding. The mistakes that did not benefit our survival did not persist, but those that did continued and further evolved. So why do we not learn from our mistakes as well as we should in health and care? Sociologists talk about agency, or each of us as individuals, and how we think and act, and social structures, what we often in lay terms call culture, the attitudes and beliefs that shape the norms or the way things are done around here. Each of these reinforce and constitute the other. At an individual level, when we make mistakes, our first impulse is to make excuses and find a reason why things happened the way they did. Explain them away. How often have we heard the words in health and care, "Oh, we did everything we could," or "This was different, it never happened before and it's unlikely to happen again." We do this because we want to protect ourselves from the pain that acknowledging mistakes inflicts on us. We're all taught from early on that to fail is wrong. It's hardly a surprise we do everything we can to avoid it. Karl Popper, a philosopher of science, highlighted our tendency to always look for the patterns that we want to see. We start with our pet theory and we look for the evidence to support this. This kind of rationalizing causes us to avoid really thinking about mistakes and learning from them, thus suppressing our creativity and imagination. This same fear is reflected at a collective level or social structure in a phenomenon we know as groupthink. This occurs when a group of people put the desire for harmony or conformity in the group as preeminent, and this results in decisions that are irrational and not based on real data or evidence. People try to minimize conflict and reach a consensus decision without critical evaluation of alternative viewpoints, by actively suppressing dissenting viewpoints and by isolating themselves from outside influences. This is particularly evident in silos in organizations and systems. It's easier to protect the group from alternative points of view if you isolate yourself from other functions. Such social structures then make it difficult for anyone who does not think the same way to be heard or even voice a different view. While such an approach protects the group from what it may see as damaging alternative views, it also insulates it from a source of creativity and innovation. Seeing the connections between things that no one else sees is another driver of creativity and innovation, and absolutely critical to learning. We need to break down some barriers. This means being honest about what is stopping us from learning from mistakes, and leaders giving teams the permission to practice, experiment, and learn from mistakes, and leading them by example, showing teams that mistakes can be powerful lessons that should be embraced as opportunities to learn. People learn, not systems and processes. Whilst we all want to learn, some of us are more open to learning, particularly from unfamiliar sources than others. To identify who those people are in a health and care system, you need to find out who the people are in your system who already cross team and organizational boundaries. These are not always the most obvious people, or the ones who volunteered for all the other change programs in the past. We outlined an approach to network analysis in our last webinar, and this helps you to identify these people. Once you identify them, understand what makes them act the way they do. Ask them what they see as the benefits of working across boundaries. They will be the greatest asset you have in showing how working across the system can enable learning and innovation. Once you have a network of people who want to generate ideas, and probably they already are, you need a way to test and learn from these ideas. Those of us in healthcare know that the gold standard in research and development is the randomized control trial. Whilst that is very difficult to implement in the real world of rapid change, complexity, high levels of demand, and information overload, nonetheless, many of the principles can and should be applied more systematically when trying out new ways of working across health and care systems. Such an approach forces us to surface our assumptions about what we think is going to happen as a result of making a change, set out how we're going to measure this effect, and over what time. One way of doing this is by using rapid cycle learning. Plan, do, study, act is a model that has been around in program management for many years, and when systematically and thoughtfully applied, enables us to accelerate innovation. It's a type of formative evaluation, or evaluation that happens alongside implementation, that allows us to measure effect as it happens, rather than after a period of time. To do this effectively, we need to understand what we think the impact will be and measure this. In order to do this, we need to be clear about what our theory of change is. So going back to our discussion earlier on, we need to be clear about what we assume will happen, when it will happen, and how we will measure its impact. There are some things over which we will have no direct control, and others which we will. The things over which we have direct control include programme outputs, but we can only ever really hope to influence outcomes and impact. An example in health and care is the assumption that by providing hospital at home or virtual ward services to frail elderly patients, we'll have the outputs of reducing hospital admissions and outpatient attendance, and an outcome of reducing overall mortality in this group. It's likely that a number of other factors outside of the control of the virtual ward programme will contribute to mortality rates, but the outputs, those around reducing hospital admissions and outpatient attendance, are realistic and measurably achievable. It's also possible that by testing our assumptions, we may find that hospital admissions actually go up, but are appropriate. Such an approach also allows us to capture unintended consequences of interventions. As we work through such rapid learning cycles, it is really important that the team designing and implementing the ideas, which should include the service user, is accountable to each other, learning as they go. Again, the theory of change approach enables teams to work together to understand what their objective is, how they are going to work through the process, how they will report to one another about success and mistakes, and build on and share learning. The team needs leadership, yes, but that does not need to be designated on the basis of seniority, but should be selected by the team. They choose a leader who understands the problem they are trying to solve and is able to create the conditions which enable the team to hold each other to account. Holding each other to account requires measuring progress. There are some key principles which the team should bear in mind as they develop the measures they will use. The most important is relevance. This is what we mean when we talk about measuring what matters. What matters to service users is the most relevant. Including service users as part of the learning team means that they are part of the measurement design process from the start. Attribution is another key principle. This relates back to the theory of change again. Are you clear that the measure you're looking at can be tracked back to the intervention you're delivering? And finally, I'd pick out well-defined. Too often we design measures that are wishy-washy and poorly defined, that then translate into poor quality and inconsistent data sets that produce inconclusive at best, conflicting at worst results. In the aviation industry, the black box is present at all times and never switched off. When something goes wrong, the black box is opened, data analysed, and the causes of failure understood, and lessons shared to ensure the failure does not occur again. And blame is only apportioned if it is clearly justified. The resulting outcome is that the error rate in aviation globally is 1 accident per 4.4 million flights. Contrast this with healthcare, where failure is chronically underreported and the number of moderate or severe harm incidents reported annually in the English NHS exceeds 50,000, according to last year's report to the Public Administration Committee of the House of Commons. There is a growing recognition, though, at the highest levels in the NHS that learning from mistakes is an absolutely essential component of transformation as we move to new models of care. Changing a culture from one of blame to one of learning will take time and persistence. It is only by opening ourselves up as individuals and as teams to practicing and making mistakes through real-life measured experimentation and peer accountability that we will really unlock the talent of the whole community to deliver continuously improving and innovating health and care that doesn't just respond to the demands of the population, but understands what is driving that demand and how to support people in new and different ways to stay well for longer and contribute to stronger, more resilient communities. Thank you for listening to this webinar series. The toolkit is constantly evolving and developing, and we welcome contributions from anyone who would like to help us develop the toolkit. And if you would like to hear more or get involved, please do get in touch.
Unmuted.
Fantastic. Thank you very much, Niamh. We've received some great questions so far. As a reminder, if you'd like to ask a question, there's still time. Just type your question into the questions box on the GoToWebinar panel. Niamh, the first question we have is, I really like the idea of the black box in healthcare. In your experience, is there a way to standardize the things that we measure, or should this be focused around a particular task?
Muted.
So the first thing I guess I would say is that we have lots of standardized measures in the NHS particularly, some in social care, but probably fewer than we do in the NHS. And these are routine measures that providers have to report on regularly, and as I mentioned in the webinar, usually for compliance reasons. I think the second point is definitely the one that I would advocate. I think focusing around a particular task is a key learning experience. It's the place where we learn. We learn from doing and taking time to reflect on the doing. And the more real life that experience is, the more real life the task is, the more likely the learning is to become embedded. So I think the first step is really to identify what the problem or the mistake is. Again, bear in mind that almost all of our innovations are as the result of having a problem, having made a mistake, having done something wrong. We learn to, we examine what went wrong, and then we decide what the solution should be. What I would also reinforce, though, is the importance of it being a collective process. It's not a process that we should be undertaking in isolation on our own as individuals. It has to be a collective process. And I would also, I would refer people to the work of the late Professor Aidan Halligan at the NHS Staff College. His work is still widely available, who was very much an eloquent advocate of the importance of using mistakes in healthcare as opportunities for learning. But again, he was a strong proponent of the team doing this collaboratively, doing it together and doing it situated around a real task, a real event, and a real mistake that they all made together, not attributing blame, but talking together through a process called after-action reviews, which is a process that has come from the US military, where they look in minute detail at the whole event and examine what was it about their own actions as individuals, their collective actions as a team, and the social structure in which they are embedded that contributed to the mistake. How can they remove those contributions to the mistake to ensure that what happened never happens again?
Unmuted.
Okay, thanks, Niamh. The next question we have is, how can we support our organizations to move from blame to one of learning when we have external above pressures, for example, policymakers or regulators?
Muted.
I would probably start off by saying that let's be clear about how blame particularly is different from peer accountability. Blame for me is about pointing fingers. It's about finding somebody who can shoulder responsibility for mistakes, thereby usually shutting down a conversation. So once you've found somebody that you feel is to blame for or responsible for a mistake, you no longer need to engage in a learning process. So it actually shuts down a conversation. And I think it's a very easy thing to do. It's relatively short term, and I think when you're up against pressures as an organization, it's easy to see why that becomes the default position. It is much harder to be accountable to each other as peers, to be accountable as a team, and to work through a process of learning from mistakes. But I don't see that we have any choice if we really want to embed learning throughout a system and we want to become a system that is known for innovating and constantly improving. I think that is the fundamental shift that the organizations and systems within health and care do need to make. And I think the concept of peer accountability actually gives us an opportunity to rethink how blame works, because peer accountability is all about how we work together collectively as a team, how we account to each other for our learning, the tasks that we're practicing, the tasks that we're learning from, the tasks that we're refining on a constant iterative basis, and that will include failure, learning from failure, as well as celebrating and accounting to each other for our successes. And I think some of the incentives that we need to look at within health and care systems that need to be put in place to reinforce that kind of behavior are rethinking how performance is managed across these systems. So we focus far too much on individual performance in the NHS and in social care. We need to focus more on team performance around collectively accountable tasks. And this needs to be reflected in the way that regulators also regulate health and care. And I'm not just talking about the quality regulators, the finance regulators. I'm talking about the professional regulators. So the Royal Colleges for medical professions and other healthcare professionals, as well as those bodies that regulate social care professionals. Are they incentivizing professionals to think collectively as teams or as individuals? So we need to figure out how the social structures that we're placing around individuals reinforce that process of cognitive dissonance that we talked about in the webinar, and we need to change those so that the focus is on really learning from the evidence in front of your own eyes, as well as structuring a process which enables you to get at that evidence more easily.
Unmuted.
Great. Thank you very much for that, Niamh. Well, unfortunately, we've run out of time for today. If we didn't get to your question, please feel free to email us and we will follow up with you directly. This webinar series is running in parallel with our healthcare evaluation webinar series. The next webinar is on economic evaluation methods of new models of care on the 24th of March. We hope you'll be able to join. If you have any colleagues who you think might be interested in this topic, please feel free to forward the webinar invite. Thanks again for joining us, and we hope you'll be back at the next Optimity Advisors webinar. Thank you.
Muted.